healthcare team. Nutanix is a software and hybrid cloud company that enables healthcare organizations to simplify operations and focus on delivering better patient outcomes and clinician productivity. Please visit our website at nutanix.com/healthcare for more information. Now I'd like to welcome everybody to today's session, Clinical Workforce Evolution. Our session moderator for today will be Midori Kondo. Now I'm going to introduce our esteemed panelists. First, we have Dr. Aileen Murphy, Medical Director of Informatics at San Ramon Regional Medical Center and Chief Medical Information Officer at Epic Care. Next, we have Dr. Swamy, Medical Director, Imaging, Radiation Oncology at Epic Care. And finally, we have Dr. Ghassan Jamaleddine, CMO of Alameda Health Systems. The panelists' full bios are available on the SoCal HIMSS event page. Thank you.
Thank you, everyone, and welcome to our panel. I'm very excited and feel very privileged to be moderating this session today. Let's see, we just have to get Dr. Jamaledine's video ready to go, and we will get started.
Midori, it says you can't start your video because the host has stopped it, so you have to do something from your end. All right.
Yes, there you go. Perfect.
Okay.
Thank you.
Thank you.
All right, welcome. So a little bit of background on this session. You know, we've actually seen a lot of challenges with COVID, and a lot of the focus has been to date in the last year talked about the challenges and just really surviving over the last year. And for this session, we really wanted to focus on moving forward and really thinking about the lessons learned and how we can learn from all of you and what you've been doing in your organizations to really help other organizations with this shift and think about some of the things that they could be applying to their healthcare organizations. We know that our clinical workforce has had to slide through the change management curve. And so, you know, all of you probably know, being physicians, where you've had to go through that shock and frustration to quick decision making and getting to solutions quickly. And so that is really sort of the theme of this whole evolution that we really wanted to provide today. And I thank you for being here today, and let's jump right in. So our first sort of question is this pivoting point with COVID. And as mentioned, COVID certainly forced this rapid change in the healthcare system and how we think about delivery of care. What do you feel, Dr. Jamaleddine, I'll start with you, are the most critical aha pivotal moments from the last year?
Good morning, and thank you. Thank you for having me on this session. Are you able to hear me well?
Yes.
Okay, great. Great. So, you know, things really came to us sort of in an avalanche. And, you know, as healthcare system, we were always in the eye of the storm, and we always, you know, tried to prepare. You know, I personally went to medical school in the Civil War. You know, I trained in the AIDS epidemic in New York. Then we have observed September 11, then Zika, then Ebola, then, you know, Superstorm Sandy. But again, you know, this came to us like an unprecedented, and lots of aha moment came. You know, in our health system, we went on a new electronic health record at the end of 2019, just like, you know, shortly before this has started. And then, you know, the sort of 36 cases from Wuhan were reported, and we had experience with SARS-1, and we were just like observing like closely. But then, you know, in February, like 6, the first case was reported from San Jose in California, southern of Alameda County. And it was a woman, 58-year-old woman who died of a cold-like symptoms at home, but she never traveled. And they couldn't, you know, pinpoint initially what she died of, except of an upper respiratory tract infection, but then it proved to be of COVID-19. And then a year later, we have lost 500,000 lives in the United States. Through this journey, you know, we observed what happened in Italy, we observed what happened in New York, and here in California, we were just like trying to prepare, just using the quote from a basketball coach who says, failing to prepare is preparing to fail. And we're looking at everything. We had to really prepare our workforce to face this epidemic, and looking at what happened, from the PPE, from utilizing the health system to treat the patients, but also we had also to care for the patients who we care for every day, from a healthcare perspective. So we found that really the digital world, the electronic health records, the integrated electronic health records that we put in our system was a lifesaver. So that was really a big aha moment that really showed the value of this tool for us as healthcare workers. And I have lived through the days when it was launched and how painful it was, and how it was perceived as really a barrier between us and the patient, in sucking us the time that we do, and then looking at the screen, not at the patient. But at that moment, I saw really the value where we pivoted to use televisits and try to connect effectively with our patients who could not come to the hospital. The other thing really is the uncovering of the weaknesses in our healthcare structure. The relationships between the federal, the state, the county, it was tested to the very end, how effective or ineffective it was. The positive thing that we have learned is our ability to collaborate at the level of science, at the level of epidemiology, at the clinical level. The way the vaccine was developed was really amazing. The virus was sequenced in a very short period of time. The vaccine race went on, and in 6 months we had very effective vaccine, unprecedented in their efficacy. So another aha moment. And most importantly, I think, I want maybe like last but not least, there are many, we are still learning about this, is really the healthcare disparity. The pandemic has affected the most vulnerable, the people of color, the people of low income, and it showed also how our healthcare system did not really address this as much as it should. So these are just some aha moment I would share, and I hope it will open the discussion, Midori, in the way you like it.
Thank you, Dr. Jamaleddine. Certainly, there were these moments where we had prior to COVID where we had pockets of telehealth, right? But certainly there was this big push and really this rapid change that happened. Dr. Murphy, just to follow up to what Dr. Jamaleddine said, being the CMIO and having to now shift in this technology world and really pushing something that was a pocket into the day in the life. Tell us a little bit about your aha moment.
So yeah, I would say that being in ambulatory medicine versus in hospital medicine, the aha moments were quite different. And I would echo what Dr. Jamaleddine said. It was definitely a dynamic situation where you kind of had to be very dynamic and flexible in what was being offered. And at the heart of it, it was just all about patient care. And so trying to make sure that the patient care was still accessible and that it could still be done. I think that was, while it was challenging, it was definitely something that was spearheaded and everyone came together and could work together to make that happen. And we definitely had to leverage technology to be able to do so. And so the aha moment was using things that were that you would typically use outside of patient care setting, outside of a hospital or even clinic setting, and being able to use those same tools. I mean, initially, even though it wasn't necessarily HIPAA compliant, people were trying to FaceTime, right? Because they knew that was something that was easy enough, that was very similar to even trying to make what would have been considered a house call in prior years, right? So things where we had to leverage technology to now be more compliant, HIPAA compliant, more secure for the patient, have remote monitoring, things that would be more clinical based, was that aha moment for me that we have all the tools, we have it available. It's not like we're doing it from scratch. And then I would say that next aha moment was that trying to shift that workflow to have it be now more technologically advanced. As someone that's knee deep in informatics, it's easy for me to say, but to make sure that all the physicians and other providers could have that ability, that was not necessarily my own aha moment, but for other providers to make sure that they're going to have to be a little bit more progressive and getting over that hump, getting over that initial struggle and challenge was definitely something I had to bring up to others as their own aha moment.
Great, thank you. So Dr. Swamy, one of the other pivotal points that Dr. Jamaleddine mentioned was about health disparities. And, you know, health disparities have been a well-recognized challenge in the world today, including the United States, which has, you know, some of the best resources in the world. In addition, the foundational elements have been missing from the underserved population to get patients to the next level. What are some lessons we have learned from the current pandemic that can be applied to deliver healthcare in a more equitable manner? You're on mute.
Can't hear you.
Can't we? We have just a few technical difficulties. Let's see if we can make sure that we have Dr. Swamy on mute.
Can you hear me now?
Yes.
Yes, we can.
Sorry about that. Okay, so first thing right there, learning to use technology.
Yes.
You know,
it's a real live example,
school, right? It's a real world example right there for helping with healthcare disparities. And so it's a well-known phenomenon. It was, as Dr. Jamaleddine said, it became even more highlighted that many of us that work in healthcare well recognize it. And even when you recognize it, do we have the tools to actually address it? And that I think is the real conversation, and what is going to happen at the local level. Obviously, you know, there's only so much you can do at locally, regionally, nationally, and you can even take it up to the world stage. So I was at a TED-Med conference a few years ago, and usually if you've been to TED-Med, you have a question. And they start the first part of the question, and one year was, what if? So my question that year was, what if it didn't matter who you are or where you are or how much money you had or who you know, right? To get the healthcare. Why is it that people feel the need to go to some doctor or some other place and there's going to be a difference in care? So I think the problems are well known. I think it's to design the solutions. So one of the things that came out of COVID is we were able to deliver care where the patients are, right? At their homes, in their communities. You don't have to go to the ivory towers or the meccas and deal with parking and get lost in the labyrinths of hallways of God knows where. And, you know, all of those things we were able to try to overcome in delivering the care where the patients are. And I think that is something, and in their communities. And if you think back to years ago, where you think back to your family practitioner, that was a person in the community, that lived in the community, that knew the community. And we've been moving away from that. And I think that trust that's built between the physicians and their patients, when they're not in the communities, that goes away. And I think it will help to get us back into the communities and bridge that gap. I think the second thing is what helped with that was digital stuff, right? And I know that's like the wrong thing to say at a HIMSS conference when I say digital stuff, but that can mean everything from your broadband access, right? We're fighting over, you know, some places have one or two, and you got to pay, you may be right on the edge of your income limit, so you can't afford the $50 or $60 when you have limited income, or you don't have secure access, or that access goes in and out while you're in the middle of a visit, or you don't have the actual tools in your hand, whether it's a phone or a laptop or whatever it is, to connect with your doctors. So I think that is the second piece. And of course, along with that is I probably am not using the right word. Again, along with the digital stuff is the software or whatever. I know Aileen's probably cringing, Dr. Murphy, when I'm talking like this, but I think this is the level we need to be at with patients, not use complex words. Hey, use a simple platform for both physicians and patients to use, and admin teams as well. And the very last thing I will say is having the decisions be put in the hands of the patients and the healthcare teams, like the doctors that are closest to the care. And I think those are probably some of the biggest things in terms of helping healthcare disparities.
You were talking about the what if, and you know, it reminded me of a conversation that I had with Dr. Jamaleddine. During this sort of transformation, I understand, Dr. Jamaleddine, you wanted to understand whether having a telehealth visit actually impacted the quality. Can you just give us a couple of, like a minute or so, around what you learned when you actually went back to do that research around that whole delivery, and whether you were really offering quality of care with these telehealth visits?
Thank you, Midori, for the question, and thank you, Dr. Uma and Dr. Murphy. I mean, thank you really for all your comments. First, I want to tell you the data. In our healthcare system, we have what we call federally qualified health centers, and these are really geared towards the underserved. Our patients' population are the uninsured or underinsured. And we invariably had like a large percentage, I would say above 5, maybe 5 to 10% of no-show rates. Our patients have to leave their work to come to our wellness centers. They have to leave sometimes their family, and they have to travel. The no-show rate with the televisit became almost zero. I mean, this is unprecedented. So I was really concerned about patients who are not coming to like have the physical exam. And, you know, I'm an old-fashioned doctor. I like the physical exam. I teach the physical exam. You know, I have this magic touch about the physical exam. And then when we started to open up, I saw 3 patients in a row in person. And then I realized, I was asking questions. First time we're meeting, he said, yes, doctor, but we spoke on the phone. And then I did also a video with them. And I said, oh God, I started to see, what did I miss here? You know, is there something I missed? I'm a pulmonologist. I'm a pulmonary critical care physician, but mainly I get referral pulmonologists. So my patients probably have been referred by their primary care doctors. So I look at the data, I see the data. And, you know, it gave me a very sort of weird feeling, a dissonance. There isn't much that I missed. And it really gave me a striking moment. You know, I used to be a very passionate photographer, and I lived during the film time and the camera and the Kodak. And then I saw it disappearing and moving into digital. And then the camera also disappeared. It's like I don't even own cameras. Maybe if I own, I don't know where they are. It's all on my iPhone. We don't print them. It doesn't exist. So it really took me right to that moment of what is of value for the patient. What is of value for the patients? And just another story is one of my patients who I follow, they just could not come to the hospital. And, you know, they said, well, you know, we are running out of the inhaler. So, you know, I wrote the order on my device, and I connected with the pharmacy. We delivered that same day the inhaler to the patients. And then make me think about Amazon. Why aren't we like this? And as you remember, we are really at this time of like shifting. And I remember, like, I think it was Reed Hastings in September 2011, he sent like this apology letter from Netflix. He was the CEO apologizing because he put away the CD and he wanted to go into streaming. And he visualized the streaming. And then, he apologized to the customer. The customer did not even know. They haven't tried this ecosystem yet. Now, I don't even own a CD player. Everybody has Netflix. We don't own a CD player. So it has really accelerated us in healthcare right now. And we are at this really shifting point where we have to think about the value for the patients. What is the value for the patients? We have really practiced until now, I feel, sick care. Patients come to the emergency room, patients come with fever, with symptoms. We have to move towards healthcare, towards keeping our patients healthy, towards population health, towards getting data and see how we can move forward.
Great. Yes, thank you for sharing that. I found that very interesting. I love the fact that you conducted your own sort of case series study to look to see how you're delivering that care. And Dr. Murphy, I mean, we've talked about this sort of change in this healthcare ecosystem. What opportunities do you feel exist for patient care moving forward?
Well, so I think it's really exciting for a lot of patients because things can become so much more convenient than it was before. Going back to what Dr. Swamy was saying about not having to park, not having to go into these large buildings or areas where it's like difficult to even maneuver, right? A lot of people like their local community. And so with COVID and everything, the silver lining is that we were able to find ways to make it easier for patients to have more convenient and remote care. The challenge still is, though, the workflows that you have to do to make sure that the patients can do it, right? Making sure they do have a secure connection, that they do have a smartphone. There are some patients and even some doctors that still have flip phones, right? Some still only use a landline. And so being able to not have any assumptions that everybody has everything, that's made us at least take a step back whenever we're implementing everything, right? It's not the same as when you check in someone for an appointment that you say, okay, you have your paperwork, you do all of this that we see, and then we put you in a room. Now the phone call is, okay, we're calling you on your phone. Is this your landline? Is this your cell phone? Do you have a smartphone? In that smartphone, we're going to send you a link in a text. Can you check it? Is it working? Okay, now that it's working, this is a prompt, right? It's a completely different set of skills that you have to have, and we had to shift fairly rapidly. And so I think all of those put together makes it so that you can still deliver appropriate patient care, but you have to let go of the assumptions that everyone has everything, and that make sure that what you can offer is able to be accessed by each patient. And I think that was the main challenge, at least for us, is that recognizing that, even just because our whole office has smartphones doesn't mean every single patient that comes to us will also. So it was definitely a very enlightening moment. Not to say that it was a bad thing or a traditional thing or old-fashioned. I actually still have a camera. I still even have a Polaroid, and it's amazing how expensive they are now compared to even a smartphone because they're considered antique, right? So
well,
now it's something that's
let me
like
just
a prized possession.
Yeah, I mean, what's interesting is the Polaroid is coming back. I don't know how much you're tracking gadgets right now, but you can buy a little Polaroid that produces this like ID size pictures, and that's coming back. Like some of that technology is really coming back.
I just added it to my daughter's wish list on Amazon, of all things.
Yes.
Like, in different colors, can print different sizes. I mean, it's amazing how we can leverage things of the past to have it, when it comes back, make it something that's a little bit more applicable to like the social life. So I think the main thing that we have to remember for healthcare is that not to recreate the wheel, not to make something new, to make it work for the patient. Use whatever we already have that they're using socially, because if they use it socially, it's much easier to also use clinically.
Very good. I'm going to keep you in the hot seat for just a moment, if I may, Dr. Murphy.
Sure.
You know, I'm going to shift gears, but sort of taking some of the pieces that everybody said here. You know, the world of apps, right? We just had our emerging tech panel that was right before us, where they, you know, they were founders, and you know what was impressive about that panel is that they were still talking about, you know, the technology can really screw things up. Technology can really, you know, it can help, but it also can hurt. And really, at the end of the day, it's the clinicians and their attachment with their patients, and that empathy that has to come through with the use of technology, and that sort of new website manner that has to happen. With the world of apps and other clinical tools that have rapidly developed, particularly in the last 18 months, you know, how do you think particularly these tools could be used for the equity and care? And I mean, you mentioned some of the challenges that are faced, and Dr. Swamy did too, around, you know, the patients being able to use these tools. Can you tell us a little bit more about, you know, what do you think is sort of what's going to happen next with, you know, what do we need to help with patients and providers using these tools? Because these emerging technologies they're not going away. The entrants in right now are just incredible.
Yeah, so I'll go back to when Zoom, right? We're on Zoom, right? Zoom was never something that was initially thought of as a HIPAA compliant platform because there were problems in the past. And they were able to leverage themselves very quickly. And it's that flexibility, that nimbleness of being able to take something that can be, like I said before, used socially, that you can then use in a clinical fashion for patient care, like have it be more medical, right? And I think that with all the different apps, and I do vet my fair share, where it has to be very easy. And if it's too difficult to even download or access or find, if the brand awareness is not easy, or if it takes too many clicks, or if it's just not user friendly, if even looking at it, it gives someone chest pain just to look at it and they can't navigate through it. It has to be that simple. And there's all these little nuances, right? The buttons have to be big enough. The colors have to be pleasing. It can't be something that looks aggressive or difficult. You can't have 3 windows that have to be open in order to use it. You can't only have the mobile app. You have to be able to also look at it on your desktop and be able to do it on your phone. So there has to be usability and user friendliness across it. And I've spoken with a lot of CEOs of these applications, and I've told them that the main thing that at the end of the day, it has to be easy for patients to use. Because if it's easy for patients to use, it will ultimately be easy for the physicians and the providers to use. They're the same people, right? There's no difference in that usability. If it's difficult for the patient, it will most likely be difficult for the physician and the provider, and vice versa. And we've seen that time and time again. And so, so I think that the user friendliness is, if they have that, it's a tool that could easily be used. It doesn't have to be a fancy app. It just needs to be easily usable.
It's almost more difficult to have a highly configured app or customizable than it is just sort of basic pictures and buttons and things that you're saying.
That's right.
You know, it's very interesting.
Yeah.
Yeah. Mm-hmm. Health literacy has a new definition these days, right?
Yeah.
So Dr. Jamaleddine, going back to sort of care delivery, and more than ever, physicians are well positioned to be change agents, not only for digital transformation, but critically for a new healthcare delivery system. And, you know, particularly the opportunities to narrow the gap in care models with different populations. How are you preparing your clinical workforce to engage and to empower them to be change agents?
Again, you know, this is a very good question, and I think the discussion, you know, has started. We are like in a very, very like pivotal time, I would say, where the social contract is changing, and not only at the level of healthcare, at multiple levels. At multiple levels, healthcare has been before COVID dealing with problems of physician burnout, of healthcare cost, of how to deal with the mental health. So many of these problems are now going to face us, and we really need to have the discussion about how we should prepare our future generation. And then you can see also the generational difference between the millennial, the baby boomers, and now the Gen Z. And we are now all in the healthcare force. So we have really to give them a platform of a voice, that we need to listen to them, and we need to prepare them into a new way of thinking, what I call the healthy, keeping patient healthy thinking. Our fee-for-service structure in healthcare and our response in a reactive way to the patient illness has to continue, but also we have to really learn how we can intervene upstream. So I don't have a specific answer to this question, except that we should start having the discussion, and we need to have the new generation of healthcare providers to have a voice, at the strategy table and at the governance table, and it needs a lot of partnership. So I mean, this is my simple answer to this question. And we have to look also at the undergraduate level and the postgraduate level. We have to look at our curriculum. Knowledge is extremely important, but information is very available right now. It's very available. People can get information about any specific disease within minutes from the internet. So really having this to see how we should spend the time with the patient, I think it's going to become more important to have the empathetic, patient connection. We don't want, again, to see as this digital transformation to be like a barrier between us and the patient. So just like I always love Yogi Berra quote, he says, the future is not what it used to be. So the future is not what it used to be. We have to imagine the future.
Very good. And, I'm guessing, Dr. Murphy, with you being the CMIO, you had to onboard quite a few physicians and around sort of technology platforms. Do you have sort of insights around what you would recommend for medical schools and residency programs and really full training programs around what to do to prepare for technology? I mean, this is becoming sort of within your DNA on delivering care.
Yeah, so I would say the ones that are in training are probably a little bit more well-versed and more adaptable to it just because of the time that we're in. But the two things that I feel like training programs lack overall is the preparation for billing, just charging for your visit. That's not something that's typically taught well in training, and what to expect with the level of technology. And so every training program is quite different, even if the nuts and bolts of it are the same in clinical information, the resources are quite different. And so making sure that those trainees understand that you have to be able to use whatever resources you have and use them to your advantage and make that work. It's very difficult if you're used to having all the resources and then you have either half or none of those, trying to then deliver that same level of care. And I imagine someone that was trained at an ivory tower, if they have a rural practice, they're going to struggle. And so being able to adequately prepare that type of physician or provider about what their resources will be and what they can do in order to leverage what they do have is going to be very important. We have to be able to set realistic expectations. And I think as a result of that, many trainees that are in their particular programs look for the practice that mimics whatever their training was in, because they don't want to have that huge change. And so I think we really need to focus on a lot more community programs, regardless of, I'm a surgeon, so I I'm used to all the community programs being tied to an academic center already, right? They make us go into a community setting, a rural setting, and the academic setting so that you get the full breadth of everything. But not every training program or specialty is the same. And so we need to prepare everybody for what is to come. Now, the nice thing, or the silver lining to that for telehealth, is that you could basically be anywhere with whatever resources you want and target that same patient anywhere they are. But being able to have that connection when now it's all over the digital wave, rather than it being, oh, I see their storefront where their clinic is and I can just walk up to the clinic. It's going to be very different how someone makes that connection of who their provider is going to be.
Great, thank you. And Dr. Swamy, Dr. Murphy mentioned something about payment. So this is a great lead into a question for you around, you know, with regulatory requirements and reimbursement, and how they've really created some barriers to really delivering what you need to have in place for, or the lack of delivery that has created the challenges to where you've not been able to reach that idealized model of care. What would a payer, government, or regulatory agent need to do to support physicians in moving the needle closer to an optimal, sustainable delivery model?
So I think that's $1 million question, and it's not going to be something we answer in the next few minutes, but I think there's general principles that need to be considered. So I think a great lesson we have is the EMR, how that went into effect. We actually have a real world sort of this past decade. It was touted to be, you know, improve a lot of things. And I think it has helped, but it has also contributed to clinician burnout. It has not provided increased access necessarily to patients. And, you know, interoperability, for example, that's a word that gets thrown around all the time. But what does that truly mean? And I think a lot of times we use these fancy words and we make little changes that move the needle. And sometimes it is little changes all adding up to a big change. And that's often how a complex problem gets fixed. But also I think we need to look at making large changes. And, you know, there are things around EMRs, some of them have gag clauses in place that decreases transparency. So we talk about improving healthcare, and if you look at the airline industry, there are things where things go wrong and they learn from it. We talk about that at the clinical level, you know, whether it's, wrong medication, things like that. But overall, the lack of, I can't look at someone's images, even though I won't mention the vendor, many of us are on, I get a report, but I can't look at images, which is very critical to what I do at another center. And then sometimes it takes a week for me to get images, which can then delay care. And something I mentioned before about having broadband, I mean, they're just foundational things that need to be put in place. One of my favorite words that gets thrown around is value. Let's provide value, right? Which is quality and cost a lot of times. But yet, a lot of times, care is being delivered at the most expensive places. I think payers need to recognize how they're going to support the places where you get the most value for your care, and make it easier for those places and the patients to get their care there. So one of the things that was brought up, and it kind of ties into what Dr. Murphy said, is being able to pick your physician, right? So we talk about sometimes physician shortages, but is it really physician shortage, or is it a maldistribution of physicians? You know, is it in a certain area we have many more physicians, and in some areas there are fewer physicians? So does it really mean that if you train more physicians, they're all of a sudden going to go to, yeah, some will because you need to find a job, but at the same time, we have that example actually in the Bay Area that actually does not work. So this might be a way actually to look at the distribution of care and the training and how you provide that care. So it kind of helps with the healthcare disparities that we talked about, but also going to Dr. Jamaledine's discussion about training programs, the conversations there, and Dr. Murphy's about on a national level, do we need some super specialists do we need 5,000 of them, or can we just have 3 of them and we can call? But oh wait, they're only, you know, now we do, right, state by state credential. Every time you move to a different state, you have to get a new license, things like that. So on a congressional level, you're going to have to really rethink that about even licensing for physicians and being able to connect. And some of that, there's already movement, right? We have a lot of telehealth clinics now where there's multi-licenses that's happening for physicians and they can deliver care at different states, but it just has to be robust. And I will say, I'll end with this, which is, you know, I have an electric car, and I recently found out that electric cars came out in the late 1800s. And in the early 1900s, even in London, they actually had a whole bunch of electric taxis that were sent out and to be used. And in the early 1900s, Henry Ford actually beat out the electric car system because he was able to do mass production in factories. And then, you know, there was the finding of the gas resources, petroleum, things like that, which further, and then you needed the range because now roads were being built and cars were able to go farther. So you needed an increased range, which the electric cars at that time couldn't do. So that's how the gasoline cars essentially beat out electric cars. But now we're sitting here talking about electric cars and all these car companies trying to phase away gas cars, right? Like GM in 2035. So it's also not just the ideas, it's the right timing. And I think we are at that right timing right now to make a large innovative change. We have thought about things and we know that if we really want to do it, we can, because we did it last year. And I'm not all about cliches, but there's this saying that I read that strength comes from when you have no choice. So if we actually think about things that we need to do and pretend that we have no choice but to deliver care better, but to do this and not go back and use crutches on old systems, then I think we can actually be truly innovative in healthcare and be a leader in how we can deliver healthcare around the world, actually.
Well, that's a great closing. Nope, I don't think I could beat that in the closing. It's a great bit of history and a great lesson around, you know, looking for solutions. Some of the stuff might not have been the right time, and now's the right time. So I want to thank you all for joining us. You know, our membership is going to greatly benefit from this session. So thank you so much for your time.
Thank you.
So now we're going to turn it over. We're going to have a break and we're going to go through the sponsor slides. I'll turn this over to Joanne. Thank you.